this really, because AI is so new and developing so fast, and the impact is so big, it really takes everyone's effort to make it work. So with this, I want to introduce the first speaker this afternoon, Jennifer Gibson from University of Toronto. She is Sun Life Financial Chair in Bioethics and Director of the Joint Center for Bioethics and Associate Professor in the Division of Clinical Public Health and Institute of Health Policy, Management, and Evaluation. So she's also the lead of the Center for Resilience in the Institute for Pandemics. She focuses on health system and policy ethics, especially in the role of interaction of values in decision-making at different levels in the health system. So in the past 10 years, she has advised governments and policymakers on topics such as pandemic preparedness and response, medical assistance in dying, health technology assessment, public health surveillance, and resource priority setting. Currently, she is vice chair and member of the Ontario Health Data Council and a member of the WHO expert group on ethics and governance of AI in health. So with that, Jennifer.
Thank you so much. I found this morning's conversation, and especially the panel debrief, really, really engaging, and I'm just so grateful for the opportunity to come here. We were just saying at lunch how unnerving it is to come and speak in front of a room like this, because one feels like one's just at the starting line, just a learner. And having shared that at the table, we're all feeling that. So just want to sort of thank you for creating this learning space. Thank you, Midas, and to the Learning Health System Collaboratory for creating this learning space for all of us, and just feel so honored to be here. Perhaps I'll just say a couple of other contextualizing comments. In 2017, through our affiliation with the WHO Global Health Ethics Unit, I was invited to participate on a panel for the ITU conference, which was the first AI for Good summit. And there, the topic was going to be sustainability, ethics, and AI. And I thought, interesting. I know something about two of those things, and the third one I don't. So, of course, I knew something about sustainability, been working in the area of priority setting and health systems for years. Ethics, kind of know something about that. And AI, I thought, that's interesting. Haven't really turned my attention to that. Singularity and all that. I wonder what the ethics literature has to say on it. Radio silence. It was a real surprise to me that, in fact, very little attention had been paid to the intersection of AI, ethics, and health. And in part, I think this had to do that there were these conversations happening over here amongst computer scientists. There were some folks over here in data science who were having conversations. There were folks writing in the literature about the singularity. And there was very little conversation amongst all of us. In the end, I didn't actually, because of scheduling, I wasn't able to participate on the panel, but it got me going down this road that said, what do we need to be thinking about AI and ethics and health? And as the director of the Center for Bioethics, I felt like it was kind of my job description to look into this. So we created, in 2018, what we call the Ethics and AI for Good Health program, which we're really just building. We've got some research that is being led in large part by our research director of AI, Ethics and Health, Jay Shaw. We have just recently, in the past year, launched a professional leadership fellowship for early and mid-career health leaders on AI and human-centered leadership. We're developing some coursework, and then, of course, some of the work that I'm doing both at the WHO and within the province of Ontario in terms of data. And I've become increasingly aware that when I come into these rooms, when I compare what 2018 was like, bringing people into the room, there were like different universes talking with each other, and I'm starting to feel like the conversations of these rooms are becoming much more of a joint or shared conversation. So I just want to just make that observation and just express gratitude for everybody for being here to show up to this conversation. So today, ethics and AI for health is the tail wagging the dog, and I leave it up to you to decide what's the tail and what's the dog. But I'll be sharing with you what I'm seeing as the situation that I see where I sit. Now, of course, our conversation up to this point today, I would say, has been at the 5,000, looking to or the 0 to 5,000 view, looking to the 10,000. I'll likely be coming more so from the 10,000 view. So looking at this through the lens of governance and policy and some of the discourse that's been happening globally, and what I am craving, because I'm hearing this from our early and mid-career health leaders, is how do we translate all of those high concepts into something that will help our institutions support the folks like that we heard today. Sharon and Yasir talking about what they're trying to do in their institutions in a way that actually makes sense. Doing it responsibly, doing it ethically, bringing compassion and equity to the work that they're doing, and hence sort of capturing this human-centeredness. So I'm really inspired mostly for today's talk by these 12 early and mid-career health leaders who were pointing my attention to this. So what my aim is, what I'm hoping we might be able to do together, is to explore the possibility of what he might, as I wrote in the abstract, a mission-driven approach to AI that sustains a human-centered focus on the health and well-being of patients and populations locally and globally. And just in the last panel discussion, I was like, aha, okay, so I think some of us in the room are already moving in that direction, great. So maybe what I can do is just sort of create a bit of a space for us to go even further. So I'd like to touch on just the broad sort of topic area of risk and responsible AI and how risk is being talked about in sort of policy and governance spheres, why I'm uncomfortable with that and why I think we should be uncomfortable about it. And the reason why I think we should be uncomfortable about it is because with this focus on risk, we risk losing our focus on the healthcare mission, which is what does this mean for patient and populations, what does this mean for the providers, and what does this mean for the human beings who are going to be most affected. Talk about some challenges. Really, the challenges have already been surfaced, but I'll just add a little bit to that as well. And then just sort of leave it as where do we go from here? And this is where I'd really love to see the conversation go at the end. So maybe one of the things that I've had the opportunity to do is actually spend a lot more time reading in science technology studies work. And this idea of the socio-technical, I think, is something which is sort of at the heart of a lot of the inquiry that in science and technology studies is engaged in. So that's sort of the convergence of sociology and ethics and law and technology to really reflect on what some of the ethical, social, and legal issues are, but also being attuned to the ways in which often technology is not just simply a tool to better predict or better explain or to better get things done, but is also a complex social phenomenon. The only way in which an AI application is used is if people use it. If people actually are willing to take it up, bring it into their practice, and use it. So it's complex also because it takes this type of mix of folks in the room to make that possible. And then finally, this other dimension about what makes AI disruptive, and I've been thinking about this, is AI so special? Like we deal with technology all the time in healthcare. So what is so special about AI? And my sense is that it has at least as much to do with that it's moving beyond the boundaries of healthcare and public health as we know it. We're kind of used to the technology that we encounter on the day-to-day basis within the sphere of health and healthcare, but AI is everywhere. I mean, I was looking at dinner last night at how many of us were wearing this watch, different wristbands, but this watch, right? That is AI that we carry. This is the type of tool that we carry with us into our day-to-day lives. So AI is something that's ubiquitous. And so what comes with that is that it can start to shape us. We are no longer the tool makers. It can start to shape who we are. So when I think about this, you know, we have an opportunity, especially now, to think about what type of disruption we're hoping that this technology may have in our spaces. And of course, you know, we've got a range of different applications that are already being through research or actually through direct application being used. Most of it is probably sort of the top four. We're also hearing in population and public health, they're saying it's sort of like the under-resourced cousin in our health systems, and so they're exploring this as well. But some of these applications are, of course, as we heard this morning, are going to raise novel questions about who is disrupted, the nature of the disruption, and whether or not that disruption is for the good. So let's talk a little bit then about this first overarching theme about responsible AI and risk. And the starting point for my reflection on this was that ITU conference, AI for Good, which I could not attend, but which the proceedings were published. And Dr. Margaret Chan, who is the Director General of the World Health Organization, said in her opening remarks in June 2017, she said the following: AI is a new frontier for the health sector. As so often happens, the speed of technological advances has outpaced our ability to reflect these advances in sound public policies and address a number of ethical dilemmas. Many questions do not yet have answers, and we are not sure we know all the questions that need to be asked. And so my team and I started to go down the route of trying to articulate what some of the questions may be. And I think that we're getting much clearer in terms of there's a lot of, the questions are less to be discovered now at a higher level. There are questions around bias, there's questions about data, there are questions about equity, there's questions about digital divides, there's questions about provider implications. I think we've got a pretty good map of what those questions are. Non-exhaustive perhaps, but there's a lot of convergence happening. But then where do we go from questions to possible responses? And so this is a graphic that was created by Stanford's AI index team that showed over the duration of time, sorry, I've got to put my glasses on to remind myself what the timeline is. So let's see, from 2016 up to 2020. These were all of the different guidelines that were developed over that 4-year period of time. And so some of these, like there's the Montreal Declaration, there's the Toronto Declaration, there are various declarations from various private sector industry bodies. Microsoft has got a set of principles that were articulated. You had consensus principles, like the FAIR principles that started to be pushed out broadly into the public sphere. And so this proliferation of principles was this first moment of how do we start to identify what's at stake here for us? What ought we to be considering at this time? And so this timeline starts at 2020. Oh, but believe me, there have been principle development ever since then as well. The other thing the AI index is really I found very interesting to look at is just to see where we've come over the last 6 years in terms from a global perspective, in terms of those institutions that are moving beyond principle into actually thinking about regulation. So sometimes an ethical principle can be seen to be soft law, or policy is soft. And then you've got regulation, which is hard. But these conversations are happening in parallel in many ways. And you can just see on the map I guess this would be in the top, your top left-hand corner of the screen here, is you see over that period of time the number of countries globally that are actually developing their own regulations. And then if you the graphic just to the side of that one is the number that have actually developed an AI strategy. And what's kind of encouraging about this, when we did we did a scoping review of the literature in 2018 on ethics and global health in terms of what the literature was showing in terms of who was doing the research, where they were located, who was actually putting out recommendations. The map didn't look quite like this. It looked like Canada, US, China, the European Union, and that's pretty much where it stopped, maybe a bit of South Africa. And now we're starting to see that the conversation is becoming much more international. More folks are at the table for those conversations. And then related to that, so since that 2020 graphic from Stanford to the timeline, there have been a number of the next stage in principle development that is trying to bring us closer and closer to something like implementation. The OECD, Then there were two reports put out by the WHO expert panel on ethics and governance of AI. I happen to be on that panel. We've got UNESCO coming out, and then you've got some country-specific ones here. So USAID is coming out with material. So, there are now these steps moving beyond lists of principles and signing off on documents and sort of common agreements to be able to adhere to principles, to actually trying to say, okay, so now let's think about the use cases and let's see what those principles actually do for us, and actually doing some work for us that helps to reveal how we might actually be able to bring a responsible approach to the work that we're doing. But there's been this other development. So we've got this AI ethics principles work. You've got regulation happening. But the nature of the regulation, I think, is interesting as well. And there seems to be this sort of coalescence around taking a risk-based approach to thinking about regulation. And that may make entirely good sense, given the diversity of different applications and settings within which AI may be applied. And so maybe that sort of brought sort of the general sort of AI application, a general lens, regulatory lens, is helpful for ensuring that all applications are addressed. But there's the focus on risk is the sort of the landing place for regulation. Is something that I'm also seeing in some of the ethics documents as well. That in fact, what we really need to be doing is identifying the risks, managing the risks. And it's got me thinking, but if we focus on risk, what are we forgetting? We're focusing here, like that analogy of if you're standing under a light post, what you see is what's under the light post. You're not seeing anything else, and you assume that that's all there is. And so in some ways, I think that's where the conversation, particularly stimulated by some of the regulatory conversations, is actually focused on the one hand, this desire of countries to continue to propel AI innovation forward. They want to harness that innovation for the good, for economic reasons, perhaps, but also for their citizens. There is often this language of we need to make sure it's human-centric, but gosh, we're going to take a risk-based approach. And the picture here of the G7, their meeting in Hiroshima in May 2023, subsequently led in October to an agreement to adhere to a code of conduct as it pertained to how they would, the G7 within their countries, would actually address the use of generative AI and the bringing of that technology into those countries. And then the EU, just very recently, about last month, the AI Act also adopted a risk approach that would then align. So depending on the risk of the technology in the sector in which it would be applied, then there would be a different regulatory response. If it was unacceptable risk, that would be prohibited. If it was high risk, then there would be certain regulatory requirements and so on, and further down. And high risk is the place where a lot of health-related applications are mentioned in the documentation about this as well. So, what does this mean for us to be thinking about risk? So I'm going to just let that question float there for a second. But one of the things that I was asked by the organizers to comment on was just to sort of brief you a little bit on some of the work the WHO's been doing. And I think this is partly where some of my discomfort has started to arise. Not with WHO or my colleagues, wonderful folks, but just as it opened up this question. So the expert panel comprised over 18 months, which coincided with the pandemic. 21 experts from 19 countries and 6 WHO regions came together to begin to talk about to define what AI was, what are the ethical issues, what might be ethical principles, and 6 ethical principles were identified. They were not identified de novo. These were principles based on a review of all the principles that had been proposed previously and what we've described as consensus principles. This is where most of the AI ethics principle discussions seem to be landing in health these days, is what we've said. And so based on this, we developed a set of some 40 recommendations for designers and developers, for institutional actors, and for governments to start to think about how they might be able to put these into practice. So that was 2021, and people were pretty preoccupied with the pandemic until, of course, the announcement from OpenAI, which arose one cool October or November day in 2020. What was it, 2022? And we were like, oh, okay, something to look at over here. And so we mobilized quickly and turned our attention to think about, okay, so how might these ethical principles apply to large language models and to generative AI? And so part of our method was to say, okay, so let us think about the different contexts where we might imagine that large language models might be applied. Let us think about some of the potential benefits of its use there based on what is currently known about what its capabilities may be. Let's talk about some potential risks. And then if we know, here's the idea, if we know what the risks are, then we'll be in a better position to be able to mitigate those and to clear the way then for responsible use of LLMs in these contexts. So the questions that we posed were, from a risk perspective, were what risks we need to be addressed along the whole value chain. So the value chain meaning the AI life cycle, and which actors are best placed to address it. That was one set of questions that we sought to answer. What action should be taken in response to those risks, and which ethical principles are being engaged, and then to parse this out in terms of what the role of government would be in terms of what might follow in terms of laws, policies, and regulations. This was perhaps WHO, because it's a large organization, it's a member organization, products are developed slowly. There's a real tradition of consultation. This was one of the quickest WHO projects that I've been involved in. And so when this was released I guess it was released in January 2024, within 2 weeks or so, it was the most downloaded document of any WHO document. So people were worrying about this. They were wondering what is possible, what can be done, where can we find guidance, where might we go? And I'm not putting this forward as the answer to this, but just simply introducing it as part of the narrative. So why am I worried about risk-based approaches? I absolutely 100% think that we should be concerned with risk. So please do not get me wrong. I also think that principles might. My original background was in cellular molecular microbial biology, but I did my PhD in philosophy. So I like principles. Principles provide a way of clarifying what's at stake, and I operate within that space. So I'm not tossing those risk. I'm not tossing risk out, and I'm not tossing principles out. But I am wondering about how risk-based approaches have a framing effect on how we talk about ethics or how we talk about AI in health. And I'm particularly interested in health, obviously. I think we all are. So it seems to presume that it takes a starting point that if we're starting from a conversation about risk, the presumption is AI is going to be used in health. It's inevitable that it is going to be. So all we can do, if we just accept it's inevitable, all we can really do is manage its risks. So it's kind of like okay, we're kind of giving into this thing. It's going to be here. There might be some who take that perspective. It might also frame it as, well, gosh, we've had tons of problems, and AI is going to make things better. So all we need to do is remove barriers and mitigate those risks. So, gosh, this is like a liberating opportunity for us. And then we even heard in passing today this notion that AI is actually not the problem that we should be concerned with. People are the problem. So what we need to do is just weed out the bad actors. And so a lot of the regulation is a powerful tool for dissuading certain types of behaviors, perhaps even weeding out certain types of actors. And maybe to talk about risks as opposed to vision and aspiration or principle is a much more robust place to do so. But the framing effect is if it's simply inevitable, if we accept that this is, that it will make things better, if AI is not the problem, it's people who are the problem, then that I think sets up two unique problems for us. First problem is that and this came up earlier, and I don't know if the speaker is still here who asked the question. So is AI is the solution, then what's the problem? And so this is what I call the solution problem. So, I mean, we should be thinking about, is AI the solution to all problems? But there seems to be this sense in some of that framing, if we're only having to deal with risk, we can handle the risks because the thing's going to be used. We're going to be incorporating this in robust ways within our institution. So then what are the problems that we're seeking to solve here? It also raises for me what I've articulated as the value problem, but I heard somebody also mention this today. So if we're focusing on risks, what is happening to our attention and concern for the outcomes that matter most? Healthcare systems are designed to do certain, well, no, I'm going to take back design, because the outcomes we get are what, the way we've designed it, but the aspiration of healthcare is that we'll actually be doing good for patients and populations. And so do we have agreement on what the value is that we're actually working toward? Because we can remove risks, but if we're not actually generating the value or generating the outcomes that matter most, and to who do they matter most to? Patients and their caregivers and our communities, then what are we doing? So, what I would like us to consider is, let's not throw risk out, but let's see if there might be a way to position these risk-based approaches in healthcare. I can't speak for other industries, but in healthcare and in public health that allows us to provide a response to the solution problem and the value problem for us. So this is what I've described as a mission-driven AI approach to health. So we might ask ourselves, so what is the mission of health and healthcare? I feel like I'm kind of going into teacher mode here. It's like, anybody want to venture an answer? Actually, let me put that to you. So what is the mission of healthcare? How would you characterize the key features of the mission of healthcare? If somebody just throw out a dimension of healthcare that you would see as core to its mission.
Improve the health of communities.
Improve the health of communities. Awesome. What else? What's that? Did I hear the word prevent? Okay, prevent poor health, right? It might even be relieving suffering, right? So, all of these things that we would expect of our own health systems. There was a book written that was edited by Mark Hansen and Dan Callahan that tried to articulate the goals of medicine. And some of these were anybody who's come up through as a professional, as a health professional will know that this is part of the ethics training that you would have received. We're focusing on goals of medicine, also line up very nicely with the mantra, the Georgetown principles of doing good, preventing harm, and ensuring that patients actually have a voice. But the 4 key goals of medicine that they proposed was, we want to prevent disease, we want to relieve suffering, we want to care for the ill, and we want to avoid premature death. So that's one way that we might be able to think about what is the core mission of healthcare. And I'm going to say healthcare and public health, because our health systems are doing both, right? And so that's one possibility. We might also look at what the WHO says that might help us to understand what is that core value proposition, if you even want to put it into business terms, of our health systems. It would be perhaps what we should be the outcome we're striving toward is a state. This is going to be the big challenge. How can we achieve what WHO, as part of its constitution, that defines health as the state of complete physical, mental, and social well-being, not merely the absence of disease and infirmity. So maybe that's healthy communities. Maybe that is well-being, and that this is a fundamental right, and the health of peoples is not only good for people's bodies and minds, but it's also good for peace and security. And so it might have broader goals as well. So somewhere in here, we find some of the potential outcomes towards which we might be seeking to deploy the tools that we have available to us, of which AI might be one, if we could define the problem clearly enough to see whether or not AI is a potential solution for that. Many of you will be familiar with Eric Topol's book. Some of you will have read this book, Deep Medicine. But the one thing that I wanted to pull from this is that even if we haven't got a fast and ready sort of definition of what the core mission of healthcare is, we might be able to articulate what we hope for from the use of artificial intelligence in health settings. And here was Topol's proposition for what we might hope for, which is that it might actually free up clinicians to be able to do what matters most to patients, which is to care for them. So this idea of moving away from tapping at the computer screen to actually engaging with the patient, addressing their suffering, responding to their needs, preventing them from getting sicker, caring for them when they are very ill. And so he proposes that it's our chance, perhaps the ultimate one, to bring back real medicine: presence, empathy, trust, caring, and being human. And if those were things that, if we just imagine ourselves in times when we have been patients or been caregivers of patients, some of the things that really mattered was, yes, I have a diagnosis, but it was conveyed to me in a way that made me feel safe, even though I was flippin' scared, or my questions were answered, or I felt like I wasn't just a number, I was actually treated like another human being. Those are qualitative experiences that may also be something we may aspire towards. So can AI help with that? Well, Topol's saying, well, it's what AI's getting out of the way. AI is a barrier remover to this core mission, which is to care for people and ensure they feel cared for. So that's a third possible way we might think about how we might start to shape what a mission-driven approach might look like. Now, this got me thinking further about how, nevertheless, we are concerned about how the way algorithms are designed, and somebody mentioned they are, sort of algorithmic fairness, and then fairness in terms of the actual outcomes of care that may be provided, or performance fairness, are going to be really important. And so when we think about at a population level, some of what I've just mentioned previously is but much more at an individual level. But at a population level, we may want to gain insights about the population that we're caring about and design health services that better meet people where they're at, as opposed to sort of serving the needs of the institution. So we see, it's not a surprise that we see this sort of shift over the last 20 years towards patient-centeredness or patient engagement or patient partnership, community engagement, community ownership. And so that shift reflects that, especially when we think about this as populations, people's experiences are very diverse and their encounters are very diverse. And yet the core mission of healthcare is they can't do all things, but one thing it can do is to try to identify people who are at risk and try to intervene sooner. So this was a study, Obermeyer et al. Wrote a study about an algorithm that had been developed and deployed across a number of health systems in the US that was seeking to identify individuals were at high risk of decompensation. They had multiple chronic conditions, and so if we could intervene sooner, we might actually be able to prevent some of the, to mitigate some of the complications they might experience. And when they developed the model, they realized that there was a gap in terms of Black and white patients. And the gap was, yes, the model was successful in being able to identify both Black and white patients who were at risk, but when a Black patient was identified as at risk, it was later in their disease course. And so, it was showing up late. So it was accurate in terms of finding people who were at risk, but it created and reinforced an inequity that was pre-existing. So what was going on there? Well, part of what this was actually, in fact, doing, it wasn't so much that it was identifying people who were at risk. It was actually better clarifying who would be sort of a higher user of the system, because the basis upon which the model was developed was looking at so costs of healthcare based on somebody's in particular groups or high users of the health system have higher billing. And so if you looked at billings, then you might be able to work backwards from those billings to be able to gain some insight about what the characteristics are, what the demographic features, the clinical features those individuals are, to be able to identify, so here's the higher billers, or these ones with these particular characteristics. Let's develop a model based on that billing that allows us to better identify those people with those characteristics. And so, in fact, what it didn't do, though, was to actually identify people who are at highest risk. And that had a lot to do with how Black patients were less likely to present. They were more likely to present sicker anyway, and so, of course, they were not billing as much. So the data itself was missing a large part of the story. And so what this, when we think about, there was some of the latter discussion this morning was about getting down into the roots again about the data we're working with. One can develop models based on the data we have, which may not be the data we need. So it's really easy to find billing data. We've got systems designed to capture billing data. That's accessible. Great, let's build a model. But the data we need is harder to get, which is what are the demographic features of people who may present, what are the circumstances, and so on. So, developing models that may actually not be achieving the outcome that's desired. The stories, the data reveals stories, but it also hides stories. It reveals stories about those who create the models. We make an assumption higher users. Folks like us in the room would say, oh yeah, it makes sense, heard that before, read about it. Higher users tend to have more complex conditions, makes complete sense. But what it hid was that those higher users were already demographically biased in a very particular way. It was data that had aspirationally had been intended to create the future. We are going to design something that means that we are actually better meeting the needs of these patients. We're going to create something that will better capture them and be able to enable us to respond in the future. But in fact, what it did was recreate the past. And then finally, it raises the question, at least for me, about who's using the data, what data matters, what is interpretable, what is important, may be different from the perspective of those whose data is actually being used. Now, Ruha Benjamin, who's a sociologist at Princeton, wrote a commentary to this article. It was entitled Assessing Risk, Automating Racism, where she introduces the idea that our highly digitized and AI world is what she refers to as the new Jim Code. That in fact, because of the data that's being used, it is simply reproducing at scale the inequities that already exist within our society. So she said, human decisions comprise the data. The data is not just out there floating around. It is we decide what counts as data. And then we decide of that data which of those things will be used as information or insight, if you will. So human decisions comprise the data and shape the design of algorithms, but now hidden by the promise of neutrality, as if the data is just the data, and with the power to unjustly discriminate at a much larger scale than any biased individuals. So the power of these models is something that should put us on pause. It's not, again, there are risks that are invisible here that we need to make visible. And why? Because if the goal of our healthcare systems is to care for people, then we need to care about risk in that respect and then decide what is the best way, and is AI the best way to address that. So I have a few colleagues who have actually tried to find ways within their own health settings to marry benefit and risk, value and risk in ways that are aligned with their core mission. So I'll tell you a little bit about them. So Unity Health is a large Catholic health system in Toronto, and their VP of Data Science and Advanced Analytics is Dr. Mohammed Mamdani, who actually completed his PharmD here, and he wanted me to say, "Go Blue," as by way of greeting. So we see him as a real gain, so thank you very much. Thank you, Go Blue. But he's, over a period of over a decade, he's been rebuilding the data infrastructure within the hospital in order to make that data useful for particular purposes. And so on this little green this green panel here is it's a screenshot that I took from the hospital's webpage, where there's the heading on the page is AI at Unity Health. I, as a patient or member of the community, I can just scroll to see scroll on any one of these images to find out what the hospital is doing in terms of deploying AI related to in these particular areas. They have a report publicly available. And so I asked him just very recently how he approaches this question. I was moaning about the risk-based approach and stuff. And he said, well, let me tell you how we do that. So he said, we actually started by actually trying to articulate what value was for us. Well, I mean, if we think about it, it's about our value is that we want it to be able to be measurable, because AI can deal with things that are quantitative and measurable, that are data-like. And that can be, we want to invest in AI applications that are actually going to improve things compared to the baseline, not just for its own sake, but will we be able to see material differences in terms of mortality, or how long somebody is staying in the hospital, length of stay, or their likelihood to readmit? Can we intervene in some way to actually be able to meet patients' needs where they're at? Also, might we see a material impact on how we deliver care that could actually reduce costs, or that would reduce human effort? And he said, if somebody comes forward to he and his team, he's got about 30 folks, if somebody doesn't come forward with us with a really concrete idea, what's the problem? We're finding, we've got really long length of stay. Everything we've tried isn't working. It's not good for the patients. It's stress on the staff. If we don't get a message like that, then he said, we won't even engage. We need to know what's the difference that this is going to make, a material difference, and why, what has been tried, why hasn't it worked, and help us understand that. Then they also look at it through six risk parameters, and they maintain a registry of risks. So some of those are technical, some of those are bias-related risks, some of those may be additional sort of risks about what he calls stickiness. Is there any likelihood that if we intervene in this way, it's going to make a difference at all? It's going to look nice on paper, but is it going to take? And then they've created a number of enablers to ensure that that impact has the potential for being realized. So training has been a part of that, monitoring and reporting. And so that's some of that reporting is public reporting. Another colleague, Jeremy Petch, he created a kind of like a design lab at Hamilton Health Sciences, another large academic health science center. His background is also interdisciplinary. He has a PhD in philosophy, but now he runs a digital lab. I mention this both because about Mohammed and about Jeremy is that there's something, I saw a slide up here, which was that, how do you make, it was one of your last slides, which was, is it like, who's that hybrid person? Is it, who's the unicorn? And I think some of these folks are maybe actually be unicorns in terms of the dispositions they bring. And so one of the initiatives that Jeremy and his team worked on was with cardiologists who were really concerned about, were worrying about the number of invasive coronary angiograms that were being done. This is considered the gold standard, but they were worrying about how much this would be exposing their patients to risk of stroke or death. And having been there with a family member in the last 6 months for that conversation about whether or not an angiogram should be done, it is nerve-wracking for patients and caregivers as well. And so what they had been working on in a very clunky sort of way was developing a clinical pathway to divert patients who were at higher risk of these events to a lower risk alternative, which was cardiac CT. And so because of that clunkiness, they came to create, and they said, look, is there something that we could do differently here? Could we actually predict this sooner, faster, better? And so they worked with the data analytics team there to come up with an algorithm. But the reason why I'm presenting this is not because of what the intervention was, but really about the approach that Create takes for assessing which interventions they're willing to work with and support. And then what they use is the quintuple aim. So the Institute for Health Improvement started about 25 years ago, came up with the triple aim, then became the quadruple aim and the quintuple aim. And it may be, in some ways, an articulation of value, but also an robust articulation of what it means to advance the mission of healthcare, improving population health, lowering cost, improving patient experience, improving clinician and experience, advancing health equity. And what Jeremy and his team say, unless we see an opportunity within this proposal coming towards us to develop a digital or an AI solution, unless we see the problem is sitting in one of those buckets or more than one of those buckets, and if nothing else has worked or is working poorly, and if we don't see the value, we won't even proceed. And so making really clear both that Unity Health and Hamilton Health Sciences has meant that this is partly an educative process too, of working with their clinical colleagues and partners to really get clearer on what the problem is that's being solved, and really getting clear on whether or not AI is the solution that should be used for that particular problem. The last example I'll offer is called Data Solidarity, and this is some work led by Barbara Prainsack, who's the head of the research team on digital health governance. And so she and colleagues, she refocused on data again. She said it's data uses, not data types, shape the risks and benefits. So let's think about these data uses, and what she was thinking about was providing a different type of thinking about data governance beyond cyber risks and data quality and so on, to really be thinking about, when we're thinking about data governance, we should be thinking about this in terms of what public value is generated from the use of such data, whether or not the benefits and costs of the use of that data is collectively shared across those who may be affected. Is there spheres of control? And here some of the concern is about, sort of industry control versus control of civil society. And a solidarity-based approach is not just concerned with risks, but also with benefits. It needs to generate some good. It needs to generate some value. And so proposes 3 pillars. First of all, to think about data use should be focusing on significant public value. It should be concerned with harm prevention and mitigation. This is an and. And then where corporate data may be used that is of no public value, if it's using our data, then there should be an obligation on those who use that data which uses the language of tax here, but to reinvest. So these are the dimensions of that approach. She has since sort of shifted, particularly in response to what the European Union's doing, is now having conversations with the European Union about bringing this approach to thinking not just about data, but data insofar as it is fueling the work around AI. And so it's possible for one to imagine a situation where you might have something which is high risk and high public value, And you might say, maybe this is something to really look at carefully. Can we mitigate these risks in order to achieve that high public value or whatever the good is that one's seeking to engage in? If it's actually something that is low public value and low risk, why are we paying attention to this? If somebody wants to commercialize this, go ahead. That's of less concern. Let us put, if we have eggs to put in a basket, let's put it in a basket that is going to be of high value, either if the risk is mitigatable or if it's low risk. So they've started to develop a sort of a heuristic for doing this sorting, and anybody who does ICERs, cost effectiveness analysis, can sort of imagine that this is kind of looks a little bit like that, but you're sort of trading off two important criteria, and the willingness to pay, for example, in cost effectiveness analysis, one could imagine an analog here is social license to use an AI-enabled application, which would involve an engagement with communities and civil society, to clarify that. And so they've since developed an online tool to help people think this through. So, I wonder if there's an opportunity here these are just a few examples, but to contemplate on some of those AI-related applications or initiatives that you've been involved in that were successful. Working backwards, was part of the success not just that it was accurate, but was really that it was taken up, it was seen to be valuable, and is actually having an impact. And the impact that one was aspiring for it in terms of the mission of healthcare. So we are facing challenges, of course, to that mission the challenge of a mission-driven AI. We've heard some today. So here's a brief list. First of all, priority setting within resource limits. Somebody mentioned, it was sitting over here, about, and the examples that I gave here were from large academic health science centers with a data analytics team of 30 people, right? That is a resource, right? A resource that most institutions do not have, and they will not have. And so they will be finding themselves purchasing, vendor products more so than they'll be innovating, right? So they're going to have few innovators. Those two examples were innovation institutions. Most of our institutions will be early adopters, late adopters, or late majority, right? We're going to take this up. So if resources are then going to be invested, whether in building an analytics team or in purchasing vendor products, within resource-constrained environments, which our health systems are, that means that the money spent there is money not spent elsewhere. And so should raise questions for us about which of these investments is actually furthering the mission of healthcare, or what impact might an investment in AI applications have on our ability to meet other dimensions of our mission. We've heard about, it's so interesting, it's almost like we sat down and we co-created some of these challenges together today. This one was I've been thinking about the learning health system. I mean, are we equipped to be able to assess whether or not an AI application should be developed? A prediction model should be both developed and deployed. And so we've got clinical governance, we've got research governance in our institutions, and the ball gets passed back. And then if some actually have QI, quality improvement governance as well. The ball keeps getting tossed back and forth, and ends up in legal, and then things stop. So that is something I think that we're going to need to turn our minds to. And then finally, how institutions work with the tech sector, because some of that learning health system, it's no longer just the usual actors. I think that learning health system is, at least in Canada, we've got large national retail pharmacies getting into the game, and they've been, adjacent, but now they're partners. And then finally, this is something we haven't touched on, but it is something that colleagues are really thinking deeply about, is the environmental impact of the sort of a move towards more data-intensive interventions. So data centers and data transmission has been identified globally as contributing 1 to 1.5% of all global electricity consumption. And if we see that the global industry of AI is likely to be 15.7 trillion, but that's probably dated now, by 2030, you can see how there could potentially be environmental impacts which do rebound in terms of people's health as well. So I will leave those as the the sort of challenges, some of which we've already surfaced, maybe some new ones as well, as for where do we go from here. And I'll just thank you. Let's discuss during the final panel. Thank you. I'll just leave it there.